Thank you very much indeed. It's just fantastic to be here. Such an energetic meeting, and I'm really excited, and I'm, needless to say, very grateful to those who invited me. Now, the first thing to say is if you've got a stiff knee, it could be infected. Don't forget that. If it's stiff, you've got to run the tests and exclude infection. Although it's not so common, it occurs. So don't forget the possibility of infection. Now, there's this term arthrofibrosis that people use. And what does that mean? Because it's used too often. Specifically, arthrofibrosis means a global, a total scarring of the joint. The truth is it does exist, but actually it's really rare. And when surgeons use that terminology, I think they're using it as an excuse for not really getting things right. Usually, stiffness follows operating too soon on an angry knee, as we were talking about earlier on. Now, I do think that there are some patients who are genetically predisposed to inflammation, that angry knee, if you like, swelling and stiffness. But make life easy for yourself. Wait for the knee to settle down. The reality is most cases with significant loss of range of motion have a focal scarring, and as I'll show you, that's almost always in the fat pad, or the fat pad is swollen. And again, it's because surgeons operate too soon. Mechanical issues, such as an excessively anterior graft in the femur or in the tibia, can also have a role. Inflammation is really important. Inflammation acutely is reversible, chronic becomes scar tissue. So I've been interested in looking at the inflammatory response to trauma, and I've linked up with a group at the Kennedy Institute, which is now at Oxford University. They took 150 cases of my acutely injured knees, many of them were sports people, and we studied their synovial fluid in their blood. And we found that in the synovial fluid, a raised IL-6, interleukin-6, or just a hemarthrosis, is correlated with a poor outcome at 2 and 5 years. IL-1 has also been suggested as a cause, and anakinra is a drug that's antagonistic to IL-1, and maybe that will help in reducing stiffness, and there's work from Duke in North Carolina on that. Occasionally, I've used oral steroids, a short course of high dose, like I use for my asthma, and that can sometimes turn around the inflammatory process. And the guys in Colorado, Mark Philippon and Johnny Huard, have looked at losartan, a blood pressure drug, and they think that can reduce stiffness. So maybe in the future we'll understand proper drug therapy for the problem. Before we can talk about dealing with stiffness, we've got to understand how the knee moves and the limits of extension and flexion. There are dynamic factors that limit both of those, and then there are static factors. The limitation of extension dynamically is from hamstrings and the gastrocnemiae. The static factors are, of course, the posterior capsule, if you go straight enough, or, as I'm about to show you, the fat pad and the articular geometry. Now, this is a slice through the medial compartment in the sagittal plane, and you can see in full extension there is compression between the anterior upslope of the medial tibia and the medial femur. On the lateral side, the tibia falls away, and if someone hyperextends their knee, they'll get a characteristic bone bruise at that point here on the femur against the tibia. Normally, the fat pad is soft, and normally the fat pad is extruded with contraction of the quadriceps and a lockout, and you'll see those bulges either side of the patellar tendon. Normal knee flexion is limited dynamically by the quadriceps, the extensor mechanism, and if patients are in pain, they'll have a reflex contraction of that, preventing flexion. In the West, the most common cause of limitation of flexion is impingement between the thigh and the calf, because we're so bloody fat. Alternatively, you can have tightness in the extensor mechanism. The fat pad needs to stretch, and if that's tight, that'll be a problem. And also the articular geometry is beautifully designed to allow a great range of motion, but whilst maintaining stability. So let's have a bit of focus on the fat pad. It's the largest soft tissue structure in the knee, and yet no one talks about it. It is, ladies and gentlemen, the source of all evil in the knee. Not only is it highly sensitive with lots of nerve endings, and therefore it hurts when it's swollen and compressed, It's also full of stem cells, and I think as a result has a terrible tendency to scar up. We've written up the anatomy of the fat pad in a KSSDA a couple of years ago, if you're interested. Dick Steadman coined the phrase the anterior interval, and what he's referring to is that space between the patellar tendon and the tibia, which is open in extension and therefore accepts the fat pad into it, as you can see here, but it closes down in flexion and the fat pad is squeezed up into the tibiofemoral cavity. Again, we've written up as an MRI study, you can see some images here in clinical biomechanics if you're interested, where we were able to take the knee through a full range of movement and see what happened to the anterior interval, how it opened and closed. And you can see this dynamically. These are a series of still images put together in a cine loop. And with the knee in full extension, the fat pad's maybe 3 centimeters below the joint line, but as the knee flexes, it moves right up into the joint. So it's a highly mobile structure. And in any mechanical situation, mobile structures are vulnerable. So let's talk about the pathology. Fixed flexion is the most common cause of trouble after knee injury or knee surgery. It's a much bigger problem than loss of flexion. And the problem always occurs initially at the front of the knee. A surgeon can create a problem, as you can see here. If the tibial tunnel is way forward, it'll cause impingement of the graft, and either the graft fails or extension is blocked. The femoral tunnel here is too anterior, and this causes tension in flexion, and you either lose flexion or the graft fails. The only solution here is to remove the graft and get the knee moving and then revise it. But that's relatively uncommon these days. Much more common is a cyclops lesion. You can see this big lump of tissue at the front of the knee on the front of the ACL graft. Look at that MRI scan, and you can see how it blocks like a door jamb full knee extension. Simple solution for this is arthroscopic resection, and that will do the trick. The fat pad, though, I think is the main cause of loss of extension. If the fat pad is scarred up, if it's swollen, if it's rigid, it's like a door jamb at the front of the knee, stopping the two bones coming together. On the left, you can see a normal situation with the anterior horn of the medial meniscus going into the intermeniscal ligament, sweeping over the ACL. On the right, you can see an ACL graft and the scar coming down like a big plaque to involve the anterior horns of the menisci, the intermeniscal ligament, and there's obliteration of the so-called anterior interval. When we treat this, we always start with non-operative treatment. Most important, the patient needs to be comfortable, and we need to get rid of the inflammation. So often I'll inject steroid into the joint anytime after 6 to 8 weeks from an ACL reconstruction, and I'll put them on a prolonged course of anti-inflammatories. Physiotherapy is important with patellar mobilizations to get the fat pad moving, isometric quad sets to get the knee locking straight, and prone hangs to use gravity to stretch the knee out. The problem with using a stretch is the therapist can only hold it for a few minutes. And so increasingly I've been using this brace called a jazz brace, where you lock it in maximum extension and it's applied to the knee for 20 to 30 minutes at a time for 3 times a day. And it applies that slow, sustained pressure that will slowly deform and stretch tissues. But even with the best non-operative treatment, we can get failure. So ultimately surgery may be required, and that is an anterior interval release, a fat pad release if you like. If the posterior capsule is secondarily tightened up, you may need to do a posterior capsule release. In very extreme situations, and that wouldn't really be following an ACL reconstruction, an anterior closing wedge distal femoral osteotomy will get the foot back under the knee to improve mechanics. One thing I'd like to say is that serial casting that I was taught when I was training doesn't work and is dangerous. On the right, you can see a picture of a ischemic necrosis, the medial gastrocnemius, due to serial casting. The blood vessel got kinked. So here's that case again. We're going to release the anterior interval, and to do so, I usually use radio frequency. Here it's diathermy. This is an old video, and I'm going to cut through that scar tissue. Sometimes I put a knife in, a 15 blade, and I sweep it down onto the anterior tibia. I've always been worried about the patellar tendon, but I'm pleased to say I've never divided it. And once we've released that, it allows the menisci to start moving separate from the fat pad. And then I'll very carefully remove lumps of white scar within the fat pad. It's very important not to resect excessively. Yellow fat pad is healthy fat pad. And so I'm opening up that gap at the front of the knee, and that allows movement of the fat pad, and it unlocks the fixed flexion deformity. But sometimes that's not enough. You clear the front of the knee, get rid of the problem, and yet they still can't straighten out. In that situation, you need to do a posterior capsular release. Increasingly, I'm doing these arthroscopically, but it's quite difficult surgery, and certainly not for somebody who hasn't got the experience. Often I use a 70-degree scope. But I thought it was useful to show you a posterior capsular release done open, as I think it's more practical. So the knee in the figure 4 position, I make a medial incision on the posteromedial knee, as you can see, deepen it down to the investing fascia, so-called layer 1 of the medial side, and then I undertake an arthrotomy. I open the capsule, you can see the medial gastrocnemius here, I place retractors, and then with a knife I take the gastroc and the capsule off the femur, and I use a periosteal elevator to strip it proximally, as you can see here. Once I've done that, I keep working bit by bit laterally until I get to the midline. Then I can identify the PCL, and behind that is a septum that separates you from the posterolateral recess. So you need to, with courage, aim your knife anteriorly and cut through the septum and get yourself into the posterolateral recess, because once you're within the synovial cavity, you're safe. And once I'm in the posterolateral recess, again, I cut the capsule with a knife off the femur, strip it with the periosteal elevator, and then I get as far as the gastrocnemius, and I cut that off as well. Here you can see I've been stripping as I go laterally. You can see the lateral femoral condyle, and then here you can see where I've cut through the lateral gastroc. So I can see from the medial to lateral side of the knee. And this is a very successful technique. You can see this gentleman who had septic arthritis, really in big trouble with fixed flexion. And this is with gravity and with passively and actively get into hyperextension. Not only was he very happy, but he stopped his legal proceedings against the other surgeon, which was nice. What about poor flexion? Well, non-operative treatment is the mainstay for that. Again, we've got to make sure the patient's got good pain relief. We may want to keep them anti-inflammatories, and then we use physiotherapy. And there is a jazz brace also for flexion as well as extension. But if that fails, then we've got to think of surgery. And the first line is to do manipulation. If that was to fail, an arthroscopic division of adhesions. And ultimately, if there's a quadriceps problem, which wouldn't be the case in truth with an ACL, a quadriceps plasty. So when I do a manipulation, and sometimes that may be many months later, I think it's worth doing, even in very delayed cases. I'll only do it when the knee has lost its anger, because if you've got an angry knee, you just flare it up and it stiffens up even more and you fail. You need to grasp the proximal tibia rather than the ankle for fear of breaking the bone. I put my ear against the skin of the lateral knee and listen as the adhesions divide, crack by crack. If it goes silent, the next noise will be a loud one as you fracture. I then inject steroid into the joint, and we will sometimes do a femoral nerve block to give us a couple of days when the patient can't fight the bend that they've got using CPM, and I use anti-inflammatories for 3 weeks. If we need to do an arthroscopic arthrolysis, then we give tranexamic acid, we do a femoral nerve block, and then I get a scope into the knee, and with an instrument, either a narrow scissor punch or an old Smiley knife, I recreate the cavity of the suprapatellar pouch. I just get against the adhesions and shove proximally in the pouch, and then I shove posteriorly in the medial and lateral gutters. And then I open up the anterior intervals you saw earlier on, resect any fat pad scar, and then do a manipulation. Now, if that doesn't work, then maybe there's tightness in the quadriceps, and you need to think about a quadriceps plasty. So this is the technique I use, the Thompson quads plasty, published in 1944, and it's in Campbell's Orthopaedics. 10 centimeter anterior incision centered on the patella going proximally, expose the tendon, and then with diathermy, cut the vastus medialis, vastus lateralis off the rectus tendon, as you can see here. The next thing is to rotate the tendon to expose the intermedius posterior to it. And the contracture is almost always in intermedius. And here you can see me excising it completely, leaving a nice supple rectus femoris. You then do a manipulation, and you'll usually hear a crack, and the vasti move to the side and allow flexion. It's very rare that you need to do a VY-plasty, and you don't really want to do that because you'll depower the knee. And so I've done 2 of those in my career. We put them anti-inflammatories, get the knee moving, and those cavities either side of the rectus will fill in. It's remarkable, really, how the body heals. So in summary, prevention is always better than cure. We should do less surgery on angry knees, and we shouldn't be frightened about waiting. It does a patient a great service. The get out of jail is really the surgery I've shown you, and that's an anterior interval release or a plus or minus posterior capsule release for extension, and then for flexions and manipulation or arthroscopic arthrolysis plus or minus a quadsplasty. Thank you very much indeed.